My goal, honestly, is to have people understand that there's hyperbarics and there's hyperbarics. The amount of oxygen that you can get into your body by using a high pressure of oxygen makes it so that you wouldn't even need blood to survive
Wow.
in a high partial pressure oxygen environment.
Can something as simple as oxygen under pressure be a powerful tool against cancer?
Welcome to Metabolic Matters Podcast. Let's meet today's guest.
Hi, everybody. Welcome, welcome, welcome. You are in for a treat today with the delightful and brilliant, despite his beliefs that he's not, Dr. Alan Katz. We are going to have a very interesting conversation about all things related to hyperbaric oxygen and really understanding that, oxygen is truly at the source of life. And we're going to take this conversation on an interesting journey. And I'm very, very much looking forward to it. So thank you for being here, Dr. Alan Katz. Welcome, welcome, welcome.
Well, great. So great seeing you, Naisha. So happy to be doing this with you. Hopefully we can move this forward.
First of all, I want folks to know you. I want them to understand the many hats that you've worn throughout your career and where you are now. And towards the end of our conversation today, maybe where you hope to go in the next, the next part of your career. But let us know how you got to being kind of the guru of hyperbaric oxygen. What led to this?
Well, very nice of you to call me a guru. Interestingly enough, my career in medicine started, I guess I trained back in the 1980s. I've been in practice since 1990, so we have about a 35-year run. And the whole first part of my career was really traditional, very, very mainstream, very much hospital-based. I trained in emergency medicine. I've worked in many level 1 trauma centers. I've been on faculty. I've been the chairman and director of multiple emergency departments over the years. And I very much functioned in that world. Even when I got into the world of hyperbarics, it was initially hospital-based, very standard-based, and very much, in many respects, limited in what you can do with it. And it's been a journey for me. And it took about 20, 25 years for me to realize that there really is more to medicine than standard of care would have you realize. And that's really what opened the door for me to start exploring different uses of standard of care, either using standard of care differently, getting different therapies in the world of hyperbaric oxygen, using it to my advantage, using it to change physiology, using it to change or give the body a better chance to respond to a disease process. And in many cases, using hyperbarics to keep people from becoming diseased in the first place. So it's a really different way of looking at it. And for so many years in the hospital setting, in the mainstream setting, I was always held back, told you can't do this. It's not approved for this. This treatment can't be used for that. This treatment's not going to be covered by insurance. It shouldn't matter. When we know that there's great science to support different treatments, that really should take precedent. And you really need to start to separate out insurances from medicine. And that was kind of where things for me broke off a little bit. Fast forward to the last 10 years or so, I practice more in an environment that's outside of a hospital setting, 50-50, I would say, in regards to standard of care type practice with a little bit more functional based or metabolic approach to treating things. But that's kind of where it's weaved. It looks like you tried to ask something there.
Well, I'm intrigued because this is in the years that I've known you now. I think we were talking about that right before we started recording. About 7 years, I think we've been in each other's world. I have always been impressed with your ability to bridge the gaps, to understand the limitations of standard of care, to even understand the limitations of quote unquote alternative care. And maybe that's a really good place to start because, first of all, you have taken your expertise out of the standard environment and you have been such a support for people that are really high, high ranking individuals. So you have been the doctor for the New York Fire Department, for the New York Police Department, for many well-known, famous, athletes. You keep the people who keep us entertained and keep us safe in tip-top shape with therapies like hyperbaric oxygen and some of the other longevity tools that you use. I would love for you to tell us about some of those tools that you've used and what gave you started to allude to the courage to do more, but I'm just intrigued by the type of people you take care of. This is not esoteric and woo-woo. You take care of some of the most important people in our culture and in our communities.
There's so much of what really determines what direction you're going to go is seeing what people are looking for. And honestly, there's been a major change in the population over the last 20, 30 years. I took my practice back to the early 90s. It was very much, if you were even a little bit on the fringe of mainstream medicine, it was looked very much down on. And most of the population still went down that pathway and said, that's the right way. That's the only way, and everything else, there's a crock. There's nothing to support it. Just the population in general has moved in the right direction now, where I would honestly, probably a third of the patients that I see now are already looking for alternatives, additional ways to treat things. Not always, in lieu of standard of care treatment. Many times it's in conjunction with, it's to support standard of care, but they know that there is more to it. There's more to nutrition. There's more to different types of supplementation. There's more to using hyperbarics. There's more to fixing things. In a world that's very traditional, if take something like a meniscus in a knee. A traditional practice 25 years ago, even, it was stabilize the torn meniscus with a suture, remove the part of the meniscus that's damaged, remove the entire meniscus. We've moved away from things like that. In a regenerative medicine practice, we try to repair tissue. But to do that, we set it up so that the body repairs itself or has a better opportunity to repair itself. For example, we often use things like platelet-rich plasma.
Yes.
So I spend a good portion of my day, I'll draw somebody's blood, I concentrate their platelets, and then using ultrasound guidance, we place the platelets where they need to be. And the beauty of that is wherever the body sees a clustering of platelets, it acts as a stem cell magnet. Your body then takes over, heads in that direction, and helps with the repair. Part of what we're able to do is, in regards to bridging therapies, knowing what I know about hyperbarics lets me know that by using the appropriate protocols and oxygen dosing, I can manipulate one medical grade hyperbaric session. And we can get into that much later, what that even means at a high pressure. So a very high partial pressure of oxygen, I can double circulating stem cells. Cool. So when I take care of the average injury, I'll do an injection followed by a dive. That's it. So I have twice the amount of stem cells available to even respond to where I just placed platelets. So it's just, is hyperbarics designed, for that? Is it approved for that? No. Yeah. Does it work well for, absolutely. So it's things like that.
I love it. And so maybe this is a really good time to give some foundational groundwork for folks, because there's a lot of folks listening who may be familiar with these concepts of regenerative medicine, integrative care, bridging of the best of both worlds. But very particularly, I'm interested in you sharing with them about hyperbarics in this environment for things like longevity, prevention of disease, and even in the treatment of cancer. So can you define for us what is hyperbaric oxygen therapy? And then let's take it into the next, I would love for you to flow into the fact that not all hyperbarics are created equal. So yeah. I'm going to cue you up for that, because this is a controversial topic that everyone thinks, just walking down the street and walking into a hyperbaric oxygen, room, is going to do the same thing as it would to walk into, say, your office. So first of all, let's define it. And then let's talk about the differentiation of the therapies available today.
Well, hyperbaric oxygen is breathing oxygen under pressure.
Cool.
So it starts with, we're in a room right now breathing room air, 21% oxygen. You breathe, then air goes into your lungs. From your lungs, it moves into your bloodstream. In your blood, the oxygen attaches to hemoglobin, and then it moves around to wherever that hemoglobin can go. And just sitting in the room where you are right now at a 21% oxygen, most of your hemoglobin is already occupied by oxygen, right? So when somebody puts the little pulse oximeter on your fingers, it's 96, 97, 98%, some high number. So if somebody were to give you a little extra oxygen, it would move to 100%, but it would max out, and that's it. When we're using hyperbaric oxygen, we're now switching into an environment where you're going to breathe 100% oxygen, and the entire environment will be pressurized. What does that mean? It simulates breathing oxygen while under the ocean. And everybody knows that the deeper you go into the ocean, the more pressure there is on the outside. Every 30 feet or so of ocean water, or dive 30, 40 feet in the ocean, 30 in fresh water, that's the equivalent of another atmosphere of pressure. And what does that mean? That means that if we take somebody and give them oxygen, which is actually a gas, so lots of little gas bubbles flying around, and we compress those gas bubbles, we can get much more of them directly into tissue. That's hyperbaric oxygen. But what's amazing with hyperbarics is based on how you dose hyperbarics and how you start to use hyperbarics, you can create many, many different things. So it's one of those things in medicine and science that is so unbelievably simple, yet it is so unbelievably complex. And it's to the point where 99.9% of the population, myself included sometimes, doesn't even know what we don't know.
Cool.
And that's true, in the world of hyperbarics. So there's a lot more to it than just having oxygen. Many would consider oxygen and pressure, for example, as two different independent medications. There was some research. I mean, if you go back, I don't remember when, and Malik, done some research years back that showed if you separate the two procedures out, pressure from oxygen, there are different and individual effects that take place. And that's something that you don't think. Most people just think of it as being oxygen, but it's not. It's that pressure. Oddball facts. The amount of oxygen that you can get into your body by using a high pressure of oxygen makes it so that you wouldn't even need blood to survive.
Wow.
In a high partial pressure oxygen environment. So if I were to put you in a chamber at 100% oxygen at 2.4, 2.5, or higher atmospheres of pressure, so 50 feet or so below the ocean type of pressure, you are receiving 6 to 7 milligrams per deciliter of oxygen, which is, it's a number I'm throwing out, but that's the number, that's the amount of oxygen that you need to even survive.
Wow.
If I suck all of the blood out of your body, completely exsanguinate you, and fill you up with salt water, you survive.
Wow.
You wouldn't make it to the chamber. But in the chamber, at that point, you are alive. So it's supporting life, enough oxygen to even support life without having to be carried by blood or hemoglobin.
Fascinating.
So it's a very wild environment.
Right.
And getting back to what you were asking about different forms of hyperbarics, dose really matters. And if anybody listening to your podcast has anything to take away from this, I would hope it's that they understand that dose matters and the way that you deliver this dose matters. And it's not to say that some forms of therapy are even better or worse than others, but they're doing different things. And that's where there's a complete loss in the world. The word, hyperbaric oxygen is just thrown out all the time. It's hyperbaric oxygen in the, in the mall and the spa and the gym and your house and the medical center and the hospital. And There's monoplace hyperbaric chambers and multiplace hyperbaric chambers and soft chambers and hard chambers and steel chambers and acrylic chambers. And I think the average person just hears that and says, "Oh, it's hyperbaric oxygen." So that's, there's difference. I don't know how much you want me to delve into that, but that's the,
Well, perhaps give a few examples, because I love that you're talking about dose and duration are very important. And the combination, like you said, oxygen and pressure and the nuances and the variations there. That's a very powerful concept for people to hear, that it's not all created equal. Maybe give us a few examples of the nuances of the fact that what you're also describing, I believe, and correct me if I'm wrong, is that different doses and deliveries will have different physiologic effects.
absolutely. Yeah, see, part of the understanding with dose, probably to better drive that home, I want you to understand the concept of partial pressure of oxygen.
Great.
The atmosphere, in normal atmospheric pressure of, let's say, if you're not living, in Colorado, on the mountain, let's say 760 millimeters of mercury, something like that. 21% of that, let's say, is oxygen. So you're at about 160 millimeters of mercury of oxygen partial pressure. If you go ahead and increase somebody's pressure to, let's say, 1.3 atmospheres, and I'm using that number 1.3 because that's a very commonly used number in the mild hyperbaric pressure world. So you're taking somebody up to maybe, what is that? That's like 200 millimeters of mercury oxygen partial pressure. That's what they are receiving at that pressure and dosing. Let's say instead of putting them in a chamber with warm air and compressing to 1.3, you were able to give them maybe a nasal prong or a mask, or you did something else where you can jack it up to maybe 30 or 40%. And honestly, that's all you can. Anybody telling you that you're going to put a nasal prong or mask on, you're getting on it, that you're not getting 100%. So let's say you get it up to 40% or so. 50 for purposes of this discussion. And again, that could never happen nasally, perhaps with a mask if you tape it in place and all sorts of other things. You're now, instead of starting that at 760 millimeters of mercury, remember it's 50% of that's now going to be oxygen, 300, maybe 400 millimeters of mercury oxygen partial pressure. Take them back to that 1.3 atmospheres. Where are we? We're still well under that. We've gone from maybe, up to maybe 500 millimeters of mercury oxygen partial pressure. That's less oxygen than you can get by sitting on your couch and putting a well-fitted aviator-style oxygen mask on your face. And it becomes is that part of the therapy important? Does that make a difference? Does it change risk? Right? There's risk with oxygen.
Yeah.
There's potential fire hazard with oxygen. Yeah. It needs to be handled appropriately. Fire is oxygen, fuel, and a heat source. Well, if you're adding more and more and more oxygen,
danger,
and you're not being careful about fuel source, heat, or spark, that could be a problem. What does that mean? If you're using hyperbaric oxygen appropriately or safely, there needs to be attention paid to removing, heat source and fuel and spark. So again, differences. But getting back to the dosing, so that when you take somebody in 100% oxygen environment, which is really only available in medical grade chamber, you're starting out at 760 millimeters mercury oxygen partial pressure, and you take it up to 3, not 1.3, but up to 3 atmospheres.
Wow. And
in the multiplace chambers, up to 6 atmospheres. So you're already over 2,000 millimeters of mercury oxygen. It's just not even the same.
Whole different animal.
Different animal, different treatments.
Right.
And
lower pressure, Doc, like while you're on this topic, what types of physiological responses might you see on that 1.3, just subtle dose and, duration?
In general, at lower dosing we tend to see more responses in inflammation.
Okay.
Things like interleukin 1, 6, 17, tumor necrosis factor. Well, all of the things that are thrown out there as being inflammatory response, we'll start to see changes there. When you start to move up at the higher pressures, we see more of a bump in things like angiogenesis, which is growing new blood vessels, neurogenesis, growing new nerves. And higher and higher pressures, we start to see more and more of that stem cell release. Everything's a gradient. But in general, when we're trying to treat for, on one extreme for stem cell release, for growth and whatnot, we tend to push on one side of the experiment. We try to really push pressure and oxygen. If we're just treating more of an inflammatory response, we might tend to go so much lower exposure. It's all about balancing, oxidative stress. I know you don't like the word oxidative stress and you like redox balance, but
It's husband, not me. I understand it.
It's all about the more and more oxygen under pressure that you throw out there, you are creating, free radicals. These free radicals that are out there are good and they're bad. And these free radicals, they're trying to steal electrons from tissue all over the place. And whether they're stealing from good tissue, or cancerous tissue or bad tissue, or, that's where that balance has to be made. And so much of working with hyperbarics, especially, has to be deciding where you need to go. Are you looking to create an increase oxidative stress? Are you looking to maybe even decrease, oxidative stress? What are you trying to accomplish? And what is the safest way to accomplish that? And how it's delivered will make a big difference. We didn't even touch on things like the way that it's delivered.
Very
much, right. with free alteration. For example, we know that in order to change the response that we get, we like to manipulate something called hypoxia-inducible factor.
Very much.
And several years ago, the Nobel Prize was given out for the discovery and determination more of how HIF actually works. But something as simple as that, we're looking to create a bigger response in general. For most patients, we need to manipulate that pressure.
Got it.
So we'll typically take a patient, we'll start off at a partial pressure here, we'll bring them up over here. And then during that time period that they're at a higher partial pressure, we'll actually start to bring them down a little, and then bring them down a little, and then bring them down a little. And in these protocols, we create what I like to call paradoxical hypoxia.
Interesting.
And all that means is that I am just trying to fake the body out and make the body think that it's oxygen deprived. The body just sees that there's been a delta. The body doesn't know the absolute number.
Got it.
That delta response drives everything else. HIF. So when HIF starts to change, we can change things like VEGF. If we change VEGF, we change angiogenic. It's that whole process. So if it's something we're looking to do, that's going to be important.
I love it. Well,
So it's really,
you're making me think about a good comparison for folks who might be familiar, kind of the idea about using oral lower doses or even lower IV doses of things like vitamin C have one behavior physiologic response in the body versus high dose IV vitamin C.
it's actually the best way to look at it because, again, vitamin C, antioxidant over here, oxidative stress over here.
Exactly.
Same thing. With hyperbaric, you can really move along that spectrum. You have obviously the higher partial pressures are creating a bigger oxidative stress at lower amounts, maybe not. Interesting though, we've done some work in my practice, some of which is not even published as of yet. For example, if I take somebody and treat them with just room air at 1.3 atmospheres. So again, I'm not even adding oxygen. So I'm at 21% oxygen and compressing to 1.3. I actually start to see a drop off in interleukin 6 when measured. And I believe I spoke to you about that a number of years ago, because it's one of the ways that I think that we're going to start to want to use that alteration of pressure a little bit more to our advantage.
Yeah.
Because we see that happen actually very quickly. If I took normal baric oxygen, so now I'm just putting a mask, forget hyperbarics. Forget everything else, just some oxygen. I have unpublished data that shows I can start to also drop off on, again, I've measured IL-6. I assume it's going to apply to 617, a few of the others. I haven't looked at it.
Now, this
If
is
anybody out there wants to fund that study, let me know.
yeah, there you go. Let's talk. Well, because this is really important because a lot of times we think of, in general, oxygen therapies can be very oxidative. And in our community, what we see more often with patients in the cancer space in particular is that they're over oxidized by a lot of aggressive oxidative therapies, be that chemotherapy, radiation, high pressure, oxygen, high dose IV vitamin C, examples that actually, in a lot of situations, depending on the situation, the patient could actually make things worse.
Yeah,
So,
absolutely.
clinically trained to understand when you want to push, when you want to pressurize literally the system and create an oxidative stress, which does, in the right situation, lead to apoptosis of unhealthy cells, be it cancer, infections, etc. Or if you need to do more of a nourishing or nurturing or cooling off, if you will, like a calming down, if there's a ton of oxidative stress that's overwhelming the body, this lower, like you said, just normal amount of oxygen without pressure or very low pressure oxygen therapies can actually be the perfect remedy for that. So I think it's just great for people to understand the new.
Don't put that out as a statement yet, though, because it's still.
So, well, and this is where I think just planting the seed for people to know, okay, I need to work with a practitioner who understands these nuances and these variations, who
Yeah.
understands the goal of the therapy we're after. Like the goal, what's the end
Right.
game? Like, what are we trying to do? What are we trying to accomplish with this patient?
Absolutely.
And so one of the things I know you and I've talked about is the frustration, for instance, that a lot of people are thinking they're treating their cancer in these low oxygen, low pressure environments that are honestly, I mean, they're doing some good. Like you said, it's not causing harm, but it's not doing what they think they're setting out to do. And so this is a conversation why I'm excited about talking to you about this is that I want people to become savvy consumers, know the questions to ask and know the practitioners to look for in this. So in kind of switching gears for just a moment, please let the audience know what are the conventional indications for high pressure oxygen therapy today that are qualified by standard of care and often even covered by insurance. Let's break that down so people know exactly what those conditions are. And then we'll go take this.
Well, again, in a hospital setting or in a setting where, even in my practice now, for the standard of care practice, there's about 14 things that are considered
Perfect.
standard and approved therapy in the United States of America. That's governed by many times by the Undersea Hyperbaric Medical Society in conjunction with other organizations to achieve approval. Many insurance companies latch on. The crazy part, though, is that we'll find that there are things that aren't even considered standard of care that may or may not be covered by insurances. So it's a little bit of a slippery slope. But the things that most people know about, the bends that you mentioned before, which is really a nitrogen bubble disease.
Yeah, when
Hyperbarics is
deep and come up.
it's standard of care. It's covered. It needs to be done in the correct medical grade environment. You're trying to shrink. There's something called Boyle's law, which is saying that P1 V1 equals P2 V2. So if you increase pressure, you shrink volume.
Cool.
So it needs to be done at the right pressures for the right amount of time. That is not even to be considered, outside of that setting. When you have people that have, for example, a diabetic foot wound that meets certain criteria.
Yep.
So there's something called Wagner grade 3 or above, meaning a diabetic foot wound. And diabetics have poor neurostatus, poor vascular status. It's so hard to heal those wounds. But if they have met that level of Wagner 3 or more, it's deep. It's to the bone. The bone's involved. There's deep space infection. There's set criteria. And if they've failed 30 days or more of traditional care, and if they've been offloaded, and if they've been supported nutritionally, and if it's been debrided, and if they meet all this criteria, then throw in hyperbarics. And that's, again, another way to try to use hyperbarics to create angiogenesis, blood vessel growth, increase fibroblastic activity, all of that to try to, in an effort to try to salvage them there. You have patients that have surgical flaps and grafts.
Mm-hmm.
So in the setting of surgery, if a flap becomes compromised in an attempt to avoid additional surgery and save or salvage that flap, that's an on-label condition. So that means that surgery is done, Doppler flow studies in OR, evaluation, post-op check shows signs of ischemia. If we treat right away, sometimes even twice a day for the first few days, and then a few more days after, we can save that tissue and keep somebody from having to go back to an OR. One of the biggies in approved and standard of care is really the treatment of late effects of radiation, and that really crosses into your world all the time.
Yep.
As you know, a huge, percentage of patients with a cancer diagnosis receive radiation at some point in that care, and a very large number, and I'll say very large number, even though others will say a minuscule number, will develop what's called late effects of radiation or soft tissue necrosis, like as a result of that radiation. And I can tell you that I have a pretty big practice. I operate in multiple states. I have I see tens of thousands, patients, and of on-label patients, meaning again, patients that are in that 14 list. So probably 40% of them are late effects of radiation. So it's not as uncommon.
Wow.
And those are patients where they've received radiation to try to treat tumor. The radiation, unfortunately, has damaged some surrounding tissue, despite all efforts to try to keep that from happening. Cancer. Prostate is radiated. Radiation beam passes through the bladder. 6 months later, a year later, 5 years later, 15 years, 20 years later, they start sloughing the bladder lining, having hematuria or bleeding. We can fix that using hyperbaric oxygen with probably 70, 80% success. Again, in a high partial pressure, environment in order to regrow tissue. And it's really working off of fixing that fibrotic tissue and whatnot. Burns. When you have patients that meet certain burn criteria, and it's typically patients that have met trauma center criteria. So bad burns, and not for a little burn, but bad burns are going to be a standard of care on label treatment. There's something called osteoradionecrosis. Kind of keep in the back of your mind in your cancer space again. Also, lots of the head and neck cancers have been radiated at some point. They're then for the rest of their lives. They're in trouble if they ever need dental procedures or dental work done. We will many times use hyperbarics to try to prevent, osteoradionecrosis from happening. And that's kind of a slippery slope. Their preventative treatment is not standard of care on label, but if they have some damage already, then you're treating the damage that's there already. So you're kind of going both ways a little bit. Osteomyelitis, well, it's probably the last of the biggies, in standard of care, just a deep bone infection that's not getting better. That if you add hyperbaric oxygen along with parenteral antibiotics, you have a pretty good salvage rate.
Well, it's
I think that's
interesting.
biggies.
When I had my private practice in my town, because I lived in a mountain town, so we had it for decompression, like altitude sickness and whatnot.
Yeah.
I can't even tell you how many times I would call the hospital to get a patient in there for altitude sickness, for carbon monoxide poisoning,
Carbon monoxide, yeah, absolutely. Thank you.
or chronic infections or wounds that won't heal. And it was like a constant battle, even to get them to take these patients that were under label, that were properly.
Yeah.
It's a strange dynamic because we have such a powerful tool and it's so underutilized, I think is the point I'm trying to make.
Yeah.
Even in these indicated environments. And as you noted, in my world, I see a lot of these conditions you just talked about. People go cancer is a disease of hypoxia, of poor oxygenation in general. So you can already start to plant the seed mentally of there is huge utility for that. But the amount of patients, and we'll come back to this in a moment, but the amount of patients receiving radiation that could benefit in tandem with a hyperbaric, or at least follow up with hyperbaric, this is a whole thing that should just be like butter and jelly, right? They should just go to
even the damage. And they should just even be the efficacy of. Remember, we talked about hyperbaric oxygen at the right dosing being an oxidative stressor or increasing oxidative stress. That's what radiation does.
Exactly.
That's what,
That's
look
the
at the
goal.
look at
Right.
platinum, or, cisplatin, carbo, that's what they're doing.
Yep.
So if you really just stack these therapies,
Exactly.
much better
Exactly.
effect.
And before we go into stacking, because this is the magic, right? This is where I get excited. I want you to tell us what happens when we harness the power of oxygen under pressure to challenge cancer cells and specifically metabolically. Can something as simple as oxygen under pressure be a powerful tool against cancer?
Well, again, part of what we should start to look at is in the world of metabolic health a little bit more with hyperbaric oxygen is some of the other things that oxygen in general could even look at something like autophagy, again, cellular housekeeping, keeping everything in check, getting rid of the bad, keeping the good. There's stimulation of autophagy and the assistance in cellular rejuvenation found, which aids in everything from longevity to decreasing the incidence of cancer to, and part of why we see cancer is this chronic inflammation, this mitochondrial dysfunction, this disruption in the energy production in the process of senescence in general. But just everything goes awry. And in general, you start to see changes with these by adding hyperbaric oxygen or oxygen in general many times, back into the mix. Specific to let's say the process of anti-aging, how about like telomeres? When looking at telomeres, which is the end caps of DNA, we know that telomeres start to shorten as life goes on. When we start to apply a hyperbaric oxygen treatment protocol, we see telomere length. When we have patients that are developing signs of mental status change, forms of dementia, we know that things like what we call SAS, senescent associated secretory phenotype, again, we start to see reductions in impacts when you start using hyperbaric oxygen. Start to think of the use of oxygen and hyperbarics as something that can help with mitochondrial biogenesis, activating the certain pathways, increasing NAD, plus increasing cellular energy production, all of these things that are drivers to both decrease and limit the damage that goes on with cancer, with aging, with, again, all of the push. It's all the same process. Everything all comes down to just balancing out energy production, making sure there's enough electrons flying around and they're all balanced out and everything is all right. And that's where you get into everything from like light therapy to sound therapy to touch. I mean, all the other things that are out there that I'm certainly not qualified to speak on, but they all are working on those same pathways. And it's all about energy production. And, again, using that, it's part of what we're doing. Again, with hyperbaric specifically, we're just trying to balance oxidative. Again, I'll get away from that oxidative stress. We're trying to balance electrons. Just trying to make sure that there's enough oxygen available to move down the process of oxidative phosphorylation properly.
It's really wild to me because I was taught in medical school that hyperbaric oxygen could actually be helpful to the cancer cell. And you and I have had these conversations over the years, and you, along with a lot of research and a lot of colleagues that are expert in this arena, have put my mind more at ease about that, because what we learned as clinicians was that a lot of things you just said, driving, angiogenesis, which in cancer is not a good idea, but in healthy cells or healthy environments is a good idea. Yeah. Driving NAD or energy production, not a good idea in a cancering process, but a great idea in a preventative, healthy longevity process. Driving telomere length, not a good idea in a cancering process, but a great idea in a longevity process. What you have taught me, and the literature seems to be showing, and I'd love for you to speak to it, is that there's this really cool thing happening with hyperbaric oxygen in the environment of somebody dealing with a cancer diagnosis and an active cancering process. And that we have truly two very distinct metabolic processes happening simultaneously. One of the healthy cells and one of the cancerous cells. Can you speak to the mythology around the concern of hyperbaric actually making the cancer stronger while also helping the healthy get stronger?
There is absolutely nothing in the literature to support the fact that hyperbaric oxygen will increase the risk or the growth or the spread or the metastasis of cancer. That has been debunked over and over and over again. The theory that is most troubling for most people, honestly, is when you start to look at things like VEGF, vascular endothelial growth factor.
Yeah.
And that's taken me a long time, honestly, to really even come to terms with, because in the cancer space, it's like, we don't want VEGF. We don't want VEGF. Everything. Shut off VEGF.
Yeah.
Stop VEGF. VEGF bad.
Yeah.
One of the biggest things that hyperbaric oxygen does for you, it increases VEGF, right? So why are we throwing a therapy out there that increases VEGF when all we hear about in the world of cancer is VEGF?
Exactly.
And why are people receiving like Avastin,
right?
As the VEGF inhibitor, and then, how does this cross? And it's my personal understanding at this point really makes me believe that you have to try to just separate this into two different environments.
Yes.
You have the tumor environment itself, the tumor itself, the tumor microenvironment, and then you have the outside world. And in the traditional sense, when you're looking to decrease VEGF, for example, on that cancer patient, it's because you are trying to stop the production of blood vessel in that regard, to the vessel. Now, here's where things get crazy. If you're taking something to shut off or trying to shut down VEGF, you're saying you're going to make it harder for chemo to get to the tumor, or you're going to make it harder for anything else to get to that tumor. So that doesn't sit well with me. But more importantly, the vasculature of the tumor itself is typically in complete disarray.
Exactly.
And it's leaky vasculature. And it's that leaky vasculature that leads to a lot of the problem in tumor metastasis.
Yeah.
And it's that leaky or damaged vasculature that is now fixed by the increase specifically, to that area. It's kind of a double-edged sword. And I have a feeling over the next several years that'll be discussed more and more and more and more.
Yeah.
And there's going to be more and more papers on it because there is no definitive 100% understanding there. But that's really the most intriguing part of all of cancer care. We've seen it work. We know that happens. And in theory, that's probably why all is good. But it almost seems like you go in opposite directions there.
Well, you made me think about, you just brought something up to my mind. This is maybe a question we ask and maybe research that we do. And that you talked about, we're looking at two distinct environments simultaneously when we're applying this oxygen under pressure. And what's interesting about cancer is cancer will have an elevation in angiogenesis, but the VEGF isn't the cause. Angiogenesis isn't the cause, it's a response. And here I think is where the magic is, because VEGF expression, vasoendothelial growth factor expression, and angiogenesis expression in the cancer tumor environment is driven by inflammation, metabolic changes, and very specifically hypoxia, low oxygen. So now you're making me think, okay, great. We can increase VEGF in the healthy cells, but we are addressing simultaneously the lowering of inflammation, hypoxia.
It's that balance that is just so critical to make happen. And it's
elegant.
That's the trick.
So it's not that, okay, we have to get away from just saying, oh, we're raising or lowering VEGF. We're changing the environment for cancer where VEGF expresses. And
that is so well put, Nisha, because that's whenever I read something about cancer and I hear like lower VEGF, it just makes me nuts because of what we've just discussed. And it's the same in all these other therapies. Remember, even just plain old oxidative stress therapy.
Yeah.
The goal is to make sure that you prepare the normal tissue to the best of its ability to survive what you're about to attack the cancer cell with. And before you do major oxidative stress on a cancerous cell, you better damn well make sure that the surrounding tissue and the rest of the body can survive that push. And that's the whole process of things like press pulse,
Yeah.
right?
Yes.
That's out there, when you start to, like, not Dominic D'Agostino.
Undersea grade, Dr. Thomas.
When he's pushed his press, that's what it's really about. It's about deciding or making tissue susceptible to it, attacking, and then backing off.
I love it.
It's the same process.
Yep. Well, and it's interesting because this is where my next question for you, and I feel like I know some of the answers to this, but I really want to hear it from you. Could oxygen under pressure really hold the key in enhancing the effectiveness of standard of care cancer
Well,
treatment?
you know the answer to that without asking it.
I know, but I want you to share it with everybody else. And give
That's part of this. Remember, many patients will only subscribe to standard of care,
Right.
and will not think about doing anything a little bit more off grid.
Yep.
Doing metabolic approach or adding additional therapies doesn't mean you don't have to follow standard of care. It means if you follow standard of care, maybe do it with a little bit more thought. And I understand that you might as well use some of these other therapies that are available to make yourself better able to survive cancer therapy or make cancer therapy. Again, we mentioned it a few times. It's if you're going to do an oxidative stress therapy, make sure everything else can survive that first and then use it in conjunction. When you're ready, you had mentioned high-dose vitamin C. So like high-dose vitamin C, oxidative therapy. If you're going to be doing that, that's a great time to add things like hyperbaric oxygen at high pressure. Why? And we have you have stacked therapy. That's times to start thinking about using things, like intravenously, adding like glucosinate if you're going to go in that direction, or hypothermia treatments, or all of these patients that are in that state of anaerobic metabolism, earlier on in their courses of cancer, they're looking to really have the tumor, hit big time. That's where all those therapies come into play. They're all working together.
Well,
And there's no reason that standard of care can't combine.
Exactly. I love it. This is the bridge ultimately. And, one thing that comes up again and again and again for us in this field is patients having drug resistance or the tumor becoming more difficult to kill, especially if it's recurred, progressing. And one of the things we've seen clinically, which people will call this anecdotal, but when you've seen it thousands of times, and you've probably seen it tens of thousands of times, that when you prepare the field, if you will, with oxygen therapy or oxygen therapy under pressure, prior to a therapy like radiation or certain chemotherapies, you literally create a vulnerability and like a Trojan horse to allow the standard of care to be delivered more effectively and to penetrate into the tumor more effectively than it would without the oxygen. So it prepares the tumor to make it even more vulnerable. The other cool thing we've seen is it helps overcome drug resistance. And there's therapies that have actually been approved by standard of care as cancer treatments, though many people aren't aware of them or don't know about them. So things like sonodynamic therapy or photodynamic therapy, which are actually FDA approved treatments for cancer. A lot of people have been hearing in the news a therapy called histotripsy, which is basically a sonodynamics. It was a sound wave therapy on crack in its very powerful impact on liver tumors. That's made all the news lately. My imagination is that bringing hyperbarics prior to a session of histotripsy would actually enhance the outcome of that treatment even further. And a therapy like sonodynamic and photodynamic, they require oxygen to be effective. It's the magic. You need the three things. You need the ultrasound or the light wave, you need oxygen, and you need a photosensitizing agent. And so those three, that cocktail, when you bring a therapy like this into the mix, you have now a smart bomb at your disposal. So could you speak a little bit to any or all of those things I just threw on the table of what's getting you excited in the ways that this can be used as part of a very good standard of care approach, or even a stacked, completely integrative or alternative approach?
Well, I think it's everything that you pretty much just described, and you're much better at this than I.
30 years just as much as you.
But all of these therapies start with radiation. I mean, you know, and you've mentioned the hyperbaric oxygen works along many of the same pathways as radiation therapy. I can tell you, though, that the literature has not really supported as much as you might think.
Interesting.
That now it makes sense, but we've done studies over the years where we've taken, for example, glioblastoma patients and done hyperbaric oxygen treatment, pulled them out of the chamber, and then ran right down over to the to the gamma knife and checked. And honestly, again, some published, some unpublished, hasn't been that much of a change there. And the thought on analysis has always been that there's still too much of a time lapse there. And the only way for that to someday potentially really come to play will be if we could ever design a system where you can be radiated at the same time. Now you can't. And years ago, there was actually trials that did that, shooting, believe it or not, radiation beams through acrylic hyperbaric chambers.
Wow.
And you can only imagine what happens if you end up with destruction of an acrylic hyperbaric chamber. That's not a good idea. But so again, there's technology that's coming into play that will probably go in that direction. I think a lot of the reason you get more success, though, even now, by doing it, it's not that direct effect as much as everything else that we said before. And it was preparing tissue and protecting tissue.
Right.
It's the same as the Mark's protocol, which we kind of alluded to when talking about osteoradionecrosis.
Right.
Again, if you pre-treat tissue that's been irradiated before you go to another procedure, you decrease the incidence of destruction because radiation causes fibrosis and destruction of tissue. We can kind of fix that a little bit, in real time almost.
Amazing.
But there, with photodynamic therapy, absolutely. Again, the literature, though, is going to need to catch up.
Exactly.
The research in science is going to need to catch up, and we need to start documenting and showing what a lot of what we're talking about is even theoretical.
Right.
Like the stuff that I told you about before, when just even using 1.3 atmospheres of air, looking and interleukin, that's not published.
Right.
I have that actually on my computer over here, and I'm just trying to figure, one day I'll sit down, we'll put that out there.
I love it.
But all this stuff is nobody's looked at this before. And very few people have really separated different protocols and different dosing parameters and different ways of delivering and how much fluctuation do you need during the treatment?
Right. Well, we get to
Yeah.
do together, my friend. This is what the short and long term is to do these studies and get them out there in the world. And so that is exciting to me because you are always an innovator in this field. And I really we'll put some links in also about some of the research you have done and have published, as well as maybe what's on the horizon. But before we kind of finish this off, I want to check in with you. What are contraindication for the use of hyperbaric oxygen therapy?
It's actually really good that you brought that up. It almost never comes up. And then you start to see the whole world talking about using it.
Yeah.
There's a thought process. Again, it's from a straight safety standpoint with the fire hazard, especially once any oxygen is being added, meaning appropriate garments fuel source needs to be limited, no heat, no spark, no laptops, no phones, no electronics. I mean, you really need to start being careful if you want to keep the side down from fire risk. Outside of that, hyperbaric oxygen, for example, will lower many times a seizure threshold for patients. So seizure patients, you might want to think a little bit. You might want to make sure that therapeutics are maximized before you treat a pneumothorax. Somebody that has any small collapse of their lung can become a huge problem under pressure or coming out of pressure. Remember, we talked about Boyle's law. If somebody has a small collapse of their lung going into a chamber, that small collapse in space becomes a very big space when you're coming out of pressure.
Yeah.
That big space pushes everything over. It creates something called a tension pneumothorax. It's a life-threatening emergency, which is why you're always screening somebody to make sure that it's even appropriate to treat them. You would be shocked if you knew how many patients have small pneumothorax.
We don't even know it.
They don't even know about it because nobody because it's, the expression, it's WNL, like, it's either within normal limits or we never look. But we never look, because in real life, it doesn't make a difference. And the small pneumothorax just disappears on its own most of the time. I see that in surgical patients all the time. And so I'll get many, many patients where, they're like, this is crazy. Why do I have to look? We're going to look. And a few times a year, we find a little pneumothorax, call up the referring surgeon and say, just to let you know, your patient has a little, now we're not going to do anything about it because, again, it's not affecting them in real life, but under pressure, they're coming out of pressure, big deal. There are patients that have different electronics that need to be considered. For example, some pacemakers can go to pressure, some can't.
Okay.
Some AICD defibrillators can and some can't.
Interesting.
Most pain pumps cannot, both from a survival to pressure to the changing flow of the medication, or the flow rate change under pressure.
With ostomies or any issues with insulin pumps or even
Insulin pumps are a disaster in a hyperbaric role. Again, patients are going to be switched over to standard administration. Monitoring devices, for the most part, can't be used. Now, I'm saying this is a generalization. So when you look at the like Dexcom, something like that, again, in a medical hyperbaric environment, that's not something that you're going to be used. It's been checked under pressurization of air. Has never been checked under oxygen. Again, that's something that's going to be cheap, but it's something you have to think about. When you mention catheters and tubes, remember, air changes.
Right.
So things that are filled with liquid, not going to be a big deal. Things that are filled with air change in size and volume under pressures. Needs to be thought about when you do any of these things.
Right. And this is why this is such
cataracts. Look at, cataracts. Have cataracts, they could get worse.
Right.
There's temporary changes in vision.
Right.
All of these things, it's really balancing risk, benefit,
right,
and seeing where to go and using the appropriate protocols to try to decrease those things from happening.
Right.
Radiation-induced damage, for example, gets treated with very high partial pressures of oxygen. But now throw in a history of, seizure disorder or this, make it a little bit more complicated. We might not treat at that partial pressure. We might treat a little bit differently. We didn't mention it before. And just to put out there for your listeners, it really is important to understand where you're getting hyperbarics, who is making the decisions about your hyperbarics, and who is treating you. And I hope you leave here understanding that there's hyperbarics and there's hyperbarics. And it should not even all be called the same thing. I'm not saying there's no role for other things, but understand what you are doing it for, what you're trying to accomplish, and how to make that happen safely. And we're living in a world now where there's probably a hyperbaric center on every single street corner.
Exactly.
And, they have some of them now. You can come by, you take a quarter, you put the quarter in, and you look. But it's gotten to that point. I know of practices where they can just walk in and they again, it's maybe that is pressurized air therapy, but just understand what you're getting into and understand within the world of hyperbaric oxygen, there's full board certification in hyperbaric oxygen. So you have providers that are fully board certified in hyperbarics. You have other providers that have completed something called a PAMP program, which would be kind of a step below board certification, but it's a lot. We have other providers just simply completed a 40-hour introduction in hyperbarics and then use it. And there's plenty of other providers that haven't even done that. It's really all over the place. And it's important that you look into what it is that what you're trying to receive. There's plenty of books out there that tell patients in different tumors to go out there and find somebody to give them vitamin C, find some place to do hyperbarics, and you can live happily ever after. So going to a mild hyperbaric thing is not doing it. Having somebody give you 10 grams of vitamin C, that's not going to do it. Even worse is when they're going ahead and adding glutathione chaser to it. So they're just taking any benefit from what they might have. And we see that all the time.
Exactly.
So again, it's take what you hear out there with a incredible small and kind of really make sure you're dealing with a practice or a provider or a group that understands what it is that you're trying to achieve. and hopefully help you to get them.
I really appreciate your experience and your knowledge in this space and your enthusiasm of taking this to the next level of the proper research and backing of this, but also possible standardization or more education and empowerment to clinicians, because this is a powerful tool, but we want it to be used appropriately. And just like we see this in integrative medicine all the time, it gets a bad rap because it's not being applied appropriately. Methodology matters.
Oh, great.
It really, really does. And so, Dr. Katz, you are just such a breath of fresh air. That pun is intended, by the way, of all of this. But I really want listeners to know how they can learn more about you, your work, and the future applications of hyperbaric oxygen therapy in general, for general health, longevity, and prevention, but also in oncology. How can they learn more from you?
Well, again, I can tell you that I have a website. Website is .com, ALANKATZMD.com. Probably if you're looking to get information quicker, grab me on LinkedIn, Alan Katz MD. Same thing on LinkedIn. I put out updates fairly regularly on where we're going. I have a practice right now. We are I'm on Long Island, I'm in Manhattan, I'm in Boston, we're in Fort Lauderdale, we're in Miami. It's there.
Got a couple books.
I did some stuff. Yeah, I have a book on longevity that should be out within the next few months. Knock, make sure all that happens. But again, it's just please, if you're looking into hyperbaric oxygen, just make sure you understand what it is that you are doing and that you're tying yourself into a practice and provider that understands what it is, what it can do, what you can't do with it, and how to keep it safe. For you.
Huge. Doc, thank you so much for your precious time and wisdom. And I look forward to following your next steps as well. So all the best.
Great talking to you, Dacia. Thank you.